happy to have Dr. Rekha Srivastava ma'am with us. She is a renowned clinical podiatrist from ILS Hospital, Salt Lake. And I think today we will gather a lot of knowledge about our field. So, ma'am, the dais is all yours. You can start your presentation now. Thank you so much, ma'am, for being with us, for being with FSTN. And thank you, students, for joining the class. Ma'am.
Are you able to see in my screen?
Yes, ma'am, it's visible.
Yes, ma'am.
Okay. So today we will discuss about the diabetic foot. I'm audible?
Yes, ma'am.
Yes, ma'am.
So today we will discuss the about the diabetic foot. What is diabetic foot, and how we evaluate the high risk foot. Foot examination. What are the different types of foot examination, and how we will able to differentiate between the neuropathic foot and ischemic foot. Explain the prevention strategies to patients and the different offloading techniques. So, what is diabetic foot? A diabetic foot is the collection of the foot problems which are not unique but occur more commonly in the diabetic patient. And it is one of the most devastating chronic complications of diabetes and is the most leading cause of hospitalization and the lower limb amputation. And more than 1 lakh people leg are amputated every year, and this number is going to increase every year. Almost 85% of the amputations are carried out in the neuropathic feet, and it is due to the infection, and we can prevent if we can educate the patient and their family members. So, education of the physician, educator, nurses, and definitely the family members plays a significant role in preventing, diagnosing, monitoring, and treating the diseases of the foot. Yeah, I am audible? Hello?
Yes, ma'am. Yes, ma'am.
Yes, ma'am.
So, what are the foot facts? The foot ulcer is the most common and costly complication of the diabetes, and it is the worst than 5 most common cancer. So, what are the common 5 most common cancer like bladder cancer, breast cancer, colorectal cancer, lung cancer? So, it is the foot disease is the most worst than these cancer, and every 20 seconds a leg is lost due to diabetes. In India, approximately 77 million of people is having diabetes, and we have to take care 154 million of patients. Okay, and for that, the awareness among the masses is very necessary. So, what is the problem in India? In India, there is no podiatry course. Okay, we have the dietitian course, we have the other medical courses, but there is no structured podiatry course. And in India, there is no diabetic foot screening program. In South now there are some foot screening programs are occurred, but in West Bengal there are no such foot screening program held, and lack of podiatry services, and also the Footwears are not available. আমাদের পেশেন্টরা ম্যাক্সিমাম জিজ্ঞেস করে জুতো কোথায় পাবো, so footwears and orthotics are not available. And socio-economical factors encourages the barefoot walking. So in our city, most of the patients or family members, they are walking on barefoot. In temple, they are going barefoot, followed by they have the ulcer in their feet. Walking on the fire, using the Hawaii slipper. So these Hawaii slippers may cause the foot ulceration. Use of toe ring in the married woman. বিয়ের পর যেরকম মানে যে toe ring পরে, that causes the ulceration. You can see in this picture there are multiple these toe rings and the pile. So these ornaments causes the foot ulcer. And walking on fires. So these are the play, but it causes the foot ulceration. And in abroad, there is a health insurance. But in India, patient have to pay from their own pocket. So this is a very big problem, and the cost is huge. So these are our own clinic patient. There is ulceration, infected ulcer on the great toe. There is a non-healing ulcer for more than 5 years. This one and this is the second one. These are the non-healing ulcer for more than 5 years. And you can see in the spot there are the maggots. So these are the maggots which are coming from this wound, and this is the ant bite. This is the rat bite. This is rat bite, and this is ant bite. And this patient is coming with the foreign body prick, and this is also a neuropathic ulcer. So this is the neuropathic bilateral high risk foot ulcer on the plantar surface of the both great toe. This patient is a Purut Moshai. Profession is priest, and he is walking barefoot, and followed by there is the ulceration on the both great toe. These are at the high pressure area. This is a patient of hurricane burn. During winter season, he is having pain in the foot, and their family member give the hot fomentation to the hurricane. And this is also a new very bad case. There is a hot compression with the potassium permanganate. So they are followed by the chemical burn. So these are the infected and neuropathic ulceration. Now come to the ischemic ulcer. You can see where there is a black, we can think about it may be the ischemic. So this is a traum cut injury, and this patient is having some pain. Patient family member, they tied a compression bandage, and there is no flow in his feet, and followed by there is a gangrene of the foot. So again, this is a patient nail prick. The patient is a carpenter, and there is a nail prick in the workshop, followed by this type of injury. So this is an infected case. Again, the hot compression compressed with the hot bag, followed by this after debridement. This is the scenario, and this is again a infected case. Only happened in the 7 days, and this is a limb to life-threatening diabetic foot infection. So this is a these are the limb-threatening diabetic foot infection. So in this patient, we have to go for the metatarsal amputation. All 5 toes were amputated. In this case, there is a hot fomentation, and there is this is a limb-threatening condition. In patient during this season, patient are going to Baba Dham, and they are walking on the barefoot, and followed by this type of ulceration, and you can see there is a ulcer after the debridement. These are the common deformities which patient came through us. The first one is the hammer toe. This is the clawing of the toe, overriding. একটার উপরে একটা আঙুল উঠে যায়, তো this is the overriding of the toes, and this is the hallus varus. It rotates medially and it rotates laterally. This is the hallus valgus. So, I hope you people are come across this type of thick nails. In diabetic patient, there is a lot of fungal infection in the nail, followed by this type of thick nails. And these nails are unable, you cannot cut with a simple nail cutter. These are cut by the specialized bone cutter or the nail negligee. This is the ingrowing toenail. It happens regularly in the diabetic foot patient who are wearing the tapered shoe. The toe, there may be a ingrowing toenail. These are the cracked heels which we found in our winter seasons, and this is a very common thing, interdigital mycosis, very common in our city because there is a humid weather. Now, there is this categorization. If there is no neuropathy or no deformity, then category 0. If there is neuropathy but no deformity, no peripheral vascular disease, no history of ulceration, amputation or charped foot, or no history of bypass, then high risk category 1, and high risk category 2 if there is a neuropathy and deformity or peripheral vascular disease but no history of ulceration, amputation or charped foot. Come to the high risk category 3, there is a history of foot pathology previously, and in category 4, there is a lower limb extremity disease, active lower limb extremity disease. So these are the risk categorization. So every time, whenever you see a diabetic patient, please check his feet, and not only feet, also the shoes and socks. Why we are pressed to examine the foot and footwear? So you can, because every time patient may not complain, they have any pain or any symptoms in their foot, but we have to check their feet. So priorities of the physical examination in general scenario, we have to check from the foot to head. But in diabetic patient, we have to check from the feet to head, and that is known as the apadamasta in Sanskrit. So 30 minutes 30 seconds foot examination is any previous diabetes related foot problem, check the pulses, protective sensation is there, and the significant foot deformity. The now 2 minutes examination, so you examine is there any ulceration, callus, if the maceration, skin or infection is there. Examine the toenail. Identify the nature of any foot deformity, and examination of the footwear. As I told you, we come across a very, very bad footwear. So we repeatedly ask the patient, please change your footwear, please change your footwear. And if I show, you can see this patient are coming through this type of footwear. You can see there is a high pressure area. You can see there is a high pressure area at the great toe. You can see the patient is coming to this type of footwear. It is tied with a rope. You can see in this, there is no inner sole. There is no inner sole practically. This is the stapler. This is the foot, and this is the X-ray of this patient. You can see this is the stapler pin. Patient is walking in his home, and there is a foreign body prick of a stapler. Again, it is tied with a rope, and if you see this footwear, there is no outer sole, completely wear out the outer sole. So please check the footwear of the patient. So neuropathic foot. How do we know it is the neuropathic foot? Because neuropathic ulcers always occur on the high pressure area. You can see this is the high pressure area, and there is a lot of calluses, and the ulcer is somewhat healthy. If we debride this ulcer, we found that there is a healthy ulcer, okay? And it was a neuropathic ulceration. So there is a loss of protective sensation, and if we check the pulses, there is a well perfused and bounding pulse. So this is the neuroischemic or ischemic foot. You can see when I see this patient, his foot was completely cold, as just like ice. So it is very painful. Patient is completely restless and it is very painful. So it is cold, pink, pulses are less, or maybe in some time it is not found. And sometimes patient may feel pain or sometimes may not feel pain. So assessment of the neuropathy, how do we assess the neuropathy? There are many clinical tests, 10-gram monofilament, biothiometer, pin prick sensation, tuning fork test. So there are very simple tools, but in our basic clinical practice, we only do the two tests. This is the 10-gram monofilament, 10-gram nylon cement Weinstein monofilament. So this is the monofilament, and how do we test? We just put the monofilament perpendicular to the foot, and the areas are grade 2, first and third MTL. Initially there are 5 places, but now there is only, we can check only 3 places, grade 2, first and fifth MTL. So how we can test? You can see this video. Just put the perpendicular and place for the 2 seconds, only for the 2 seconds. And first ask the patient on their hand what type of sensation they feel, and in the same type of feeling you can in the foot. If the patient can feel in 2 places, then patient is not neuropathic, and if he unable to feel in the 2 places, then patient is neuropathic. So this is a vibration perception threshold. Again, if it is it quantify the how much the patient is neuropathic. If it is more than 15 volt, then patient is neuropathic. And how do we test? Again, this test should be done first on the hand. What type of feeling patient had? Now test on the great toe and just increase this volt. Yeah. So if it is more than 15 volt, then patient is neuropathic. So now come to the vascular assessment. You can see these are the some ischemic cases. You can see there is complete blackening of the great toe. This is again blackening of the ulcer, and this is the again blackening of the ulcer. So these are the ischemic ulcers. How do we diagnose the peripheral vascular disease of PVD? By the simple claudication. So, do you have any idea about the claudication? Anyone? Hello?
No, ma'am.
Okay. So,
No, ma'am.
claudication means if a patient is feeling severe pain when they walk on the ground, within less than 100 meter, they feel a severe pain in their calf muscles, and after taking rest, it will subside. Okay, so this is the claudication pain, and sometimes patient may complain this claudication, and if we check the peripheral pulses, there is maybe the absent. So in that case, we have to go the bedside test, ankle brachial index, and the toe pressure. So ABI is the key to early detection and management of the peripheral diseases. So this is the hallucis longus and this is the dorsalis pedis. Okay, these artery we have to feel the dorsalis pedis where there is any pulsation or not, and here it is the just behind the medial malleolus there is a artery called the posterior tibial artery. So this is the dorsalis pedis and this is the posterior tibial. So how we check? You can see this is how we check. Okay. So what is the normal ABI? ABI is normal if 0.9 to 1.3 is the normal, and it is if it is less than or more than that, then we can say the patient is suffering from the peripheral vascular disease. And this is the machine. How do we check the ankle brachial index? So if there is if we are unable to find the ankle brachial index, then we can go for the further test like arterial Doppler, TCPO2, transcutaneous per oxygen, okay, and angiography, CT angio and MR angio. There are more tests. So how do we differentiate between the neuropathic fit and ischemic fit? Very simple. Neuropathic is warm, ischemic there is no blood supply, so it is the cold. Neuropathic there is pain less, and ischemic is painful because there is no supply. And skin coloration is there is in generally neuropathic also there is no skin coloration, and it occurs at the high pressure area. Okay, this is the high pressure area, and the ischemic ulcer occurs on the margins of the toe or foot, and there is a discoloration, either black or something bluish, and there is a callus formation at in the neuropathic foot, but there is no callus in the ischemic foot. And ABI is normal in neuropathic foot and ischemic foot is less. Now, what is the basic management of the diabetic? Adequate debridement and infection control, adequate vascularity, and adequate offloading. So this is the basic tenets of the management of the diabetic foot. So this is a case, patient is coming with this type of ulceration. We have debrided this ulcer and give the indigenous offloading technique. And you can see ulcer is healed within 2 weeks. Reminded within 2 weeks. So neuropathy ulcer heals very fast. So as I said earlier, we can just callus shaving. These are the hard skin which we call the callus, and we have to shave this callus. You can see how do we shave the callus. This we have to remove in very small pieces, and don't go very deep. Okay. This is how we can remove the callus. And in generally the diabetic patient, as I have shown, the nails are very thick. No, these nails are removed in this way. So these are very thick, and we need this type of instrument to cut the nail. So this is again a very complicated case. Patient is coming this gangrene of the middle toe, and you can see complete blackening of the toe, and we after this evaluation we found that there is a gangrene and there is no flow. After angiography, you can see this is the angiography, and after angioplasty amputation was done, and again there is a blackening. So we have to sacrifice the 2 toes, and patient healed in 4 months. So in neuropathy ulcer, we took the 2 weeks to heal. But in peripheral vascular disease, it took 4 months to heal. So regarding offloading, the diabetic foot ulcers frequently occur on weight-bearing area or high pressure area of the foot, which are subjected to high pressure. And to remove these high pressure, we need the offloading. And why we give the offloading? To reduce and redistribute the plantar pressure. So there are various types of offloading. One is irremovable, which we cannot remove, and there are various types of removable devices. We will not discuss all. We can just show a picture. This is the complete bed rest, which is not possible. Wheelchair assistant, which is not possible in every patient. Crutch assisted offloading, it is also not possible in all patients. This is fell foam dressing, very easy, but sometimes may cause skin eruption due to this gum. And this is half shoes and total contact casts. It is the gold standard. It is the gold standard for the healing of the neuropathic ulcer. Now, this is the total contact cast. So, I showed this picture, a patient of neuropathic ulcer, more than 5 years. We give this type of total contact cast with window, and it will heal in 6 months. You can see we have changed this type of total contact cast for 5 to 6 times, and ultimately the ulcer was healed in 6 months, which was not healing for last 5 years. So these are the different types of offloaded shoes. This is the mid offloaded shoe. If the ulcer is in the mid foot, you can give this type of offloaded shoe.
Ma'am, there is a window opening for the ulcer, ma'am.
Yeah. In this?
Yes, ma'am.
Yeah. We are using this type of insole and give the plaster, and there is a window working cut. This is the window working cut. And through this window, patient family member can dress his wound, and they can inspect their ulcers, what is the condition. Okay. Otherwise, if we close the ulcer, there may be a emaciation and and more ulceration. Okay. And these are some offloaded shoe, front offloading and the back offloaded shoe. This is our indigenous technique of offloading. In this, this is based on the Samadhan principle of Samadhan system. In this system, what we are using, just take a 10 by 10 foam. It is not a medicated foam, just using the simple foam. Just roll it, wrap it with the bandage, and give this type of offloading. Okay? So, if the ulcer in the front, this empty heads, you can give one in the above and one just the below. So, it is the offload. If the ulcer is in the great toe, we can give only one. If in the first empty head, we can give 2 offload. These are the pressure area. Generally, in some casts, they are they are sitting on the floors, and during the prayers they are sitting on the floors, and they are followed by this type of pressure ulcers. And how we offload, we give this type of foam and just press the wound and ask the patient not to sit with the cross leg. Otherwise these ulcers never. So footwear. Why we advise the footwear? To reduction of the shock, reduction of shear, to accommodate the minimal deformity, stabilization of the deformity, preventing recurrence of the ulcer. This is very important. After healing, the patient thinks my ulcer heals and we can walk with a simple footwear or barefoot walking. Then the ulcer will again recur. So, to prevent the recurrence of the ulcer, we advise to always use this type of footwear. So there are basically 3 types of footwear. One is preventing footwear, simply this Skechers shoes or the sports shoes. These are the preventable footwear. Therapeutic footwear, these are sometimes different footwear. Most of the diabetic patients are required this type of therapeutic footwears. And the customized footwear, suppose the patient is having some forefoot amputation or toe amputation, then they require the customized footwear. So the quality, what are the characteristics of the footwear? You see, the toe box should be wide, the depth should be extra depth, appropriate insole. If you see in your footwear, there is the insole will be hardly very thin like paper, but in diabetic foot, if you see, these are the inner sole. Inner sole should be 8 to 10 mm thick. Okay, 8 to 10 mm thick, and the heel counter should be rigid. Outer sole should be rigid because there may be a foreign body prick. So outer sole should be rigid, and the rocker bottom adjust. So these are the preventive footwear. You can see the shoes. These are the therapeutic footwear. Therapeutic footwears always should be the Velcro adjustable. Inner sole should be thick and it should be Velcro adjustable. And these are some customized footwear. You can see this is the amputation. There is amputation. So this type of patient needs this type of customized footwear. And these are the different types of insole. The silicone insole, ulcer management insole, and this is the rocker bottom insole, and this is the healing insole. How do we foot care? You always ask the patient to inspect their foot by this type of mirror and cut the nails just straight across and file the side, and always ask the patient, family member to wear this type of footwear and just try in between the toes. You can see, we always ask the family members to dress their own. You can see, they are the family members. We never allow to any dresser to dress patient's own. We always ask the patient family member to dress their own. These are the general instruction for the patient which we provided to our patient. Examine the feet daily. Use this type of mirror to check their feet regularly. Foot hygiene to be maintained. If we ask that check the temperature of the water and do not walk barefoot. Use the proper footwear, and the best time for the buying of shoes is the afternoon or in the evening, because in diabetic patient there may be a swelling of the feet. Cut the nails straight across and never use this type of corn cap. See, this is after the using of corn cap. So never allowed to use the corn cap. And use the moisturizer in the foot, but except in the finger. In between the finger, we never allow to use any emollient to prevent the fungal infection. These are the simple tools which we need to start any diabetic foot clinic, and you can make your instruction like this for your patient, for in your languages like Bengali, Hindi and English, what to do and what not to do for the diabetic patient. And patient education is very important, so try to accommodate your patient and give the knowledge about the footwear. And if we try to shave the callus or try to be a podiatrist, then you can practice on this type of model like potato or sweet lime, or in this type of foot. And there, as I said earlier, there is no podiatric course in our country. But 1 year back, ILS Hospital started a hands-on practice on podiatric course. And for the area recommendation, all individuals with diabetes should have the annual foot examination, and patient with neuropathy should have visual inspection at each visit of the health clinic during by the health professional. And if there is an ulcer, then they have more frequently visit. To summarize my talk, periodic examination of foot is mandatory in all people with diabetes. Early identification of foot problem can prevent major events and reduce cost. Prevention of diabetic foot is possible at primary care setting. Education of physician, paramedics, family member and patient is very important for the prevention of foot complication. And educators, nurses are the pillars of the management of the diabetes and diabetic. Thank you.
Thank you so much, ma'am, for this beautiful presentation. This is ma'am.
Hello. Yeah. If you have any question from the audience.
Ma'am, during the neuropathic diabetes foot, you said the ulcer is healthy. What does the ulcer is healthy means, ma'am?
Ulcer is sometimes infected due to some bacterial infection, but if there is no infection, means if when we debride the ulcer, there is a granulating tissue. After debriding the ulcer, we can see the ulcer is totally red, granulating. So in this type of ulcer, there is no infection, and sometimes there is a infection. That in that time we have to give the antibiotic.
Okay, ma'am.
Yeah, any question?
Ma'am, who can do this course, ma'am?
No, we generally provide this course to the science background. If there is a nurse or any paramedics, those who are working with diabetologists, okay. Either she may be a nurse or educator or even a dietitian, so we can provide this course to you.
Ma'am, is there any such type of course in Hyderabad?
Yeah, probably in the south there may be there are very not in Hyderabad properly. There is Amrita Institute in Bombay. They can provide you the podiatric post.
Okay, ma'am.
Ma'am, I have a question.
Yeah.
আমাদের যখন ডায়াবেটিক ফুটে হচ্ছে গ্যাংগ্রিন হচ্ছে তখন সার্জিক্যাল প্রসিডিওরে ওটা ট্রিট করা হচ্ছে, বাট যখন হচ্ছে বুনিয়ান ফিট বা প্ল্যান্টার ওয়ার্ডস হচ্ছে তখন কি মানে মেডিসিনাল বা ডায়েট থেরাপিতে ওটা রিভার্স ব্যাক করা হয় নাকি ওখানেও মানে ওখানে কি প্রসিডিওর আছে?
নো, যখন আমাদের দেখছি আমরা পেরিফেরাল ভাস্কুলার ডিজিজে তখন আমরা সার্জিক্যাল ইন্টারভেনশনে যাই না, আনটিল অ্যান্ড আনলেস আমি যতক্ষণ না ভাস্কুলারিটি কারেকশন করছি, যতক্ষণ না ব্লাড সাপ্লাই হচ্ছে ততক্ষণ আমরা কিন্তু সার্জিক্যাল প্রসিডিওরে যাচ্ছি না, ঠিক আছে। আর যেটা হচ্ছে বুনিয়ান বা ওয়ার্ড, সেখানে আমরা ক্যালাস শেভিং বা ডিপ্রাইভমেন্ট করতে পারি, বাট ইন peripheral vascular disease we never go for the debridement or any surgical procedure. First you have to see the vascularity.
Okay, ma'am. Thank you, ma'am.
Ma'am, my father is diabetic and his nails are thick, the way you showed in the photos. How can I get the nail cutter, ma'am? What name is there?
This is called the nail nibbler. Nail nibbler, you can say nail nibbler.
Okay, ma'am.
Okay.
Uh,
But you should very cautious during the cutting of the nails, because sometimes the skin are attached with the nail, and before cutting the nail, you should examine the pulses. If the
Okay,
pulses
ma'am.
are not palpable, then cut the nail very cautiously.
Okay, ma'am.
Okay.
Ma'am, how can we, loosen the skin from the nail? We cannot do that, right?
No, you cannot do.
Okay, ma'am. Ma'am, why is the leg cold for a ischemic foot, ma'am? Uh,
Because there is no blood supply.
okay, ma'am. Okay, ma'am.
Ma'am, which type of ulcer takes longer time to cure, ma'am?
Generally, this peripheral vascular disease, it takes time to heal, because there is no blood supply and it is very costly also. So we are there is much it will take much long time to heal. We have to give this we have to go for the further tests like angiography, angioplasty, and after that we can assure the ulcer may heal. But in neuropathy, ulcer may heal faster, but it may recur if the patient is not caring for that.
Okay, ma'am. Thank you, ma'am.
Any further question?
What is the relation between toe ring and diabetic foot?
Yeah, I'm not. Yeah, pardon, please.
What is the relation between toe ring and diabetic foot?
Yeah, sometimes it is very common in our cases. Patients are using toe rings, and there is a cut injury in that area, because it may sometimes pressurize, and there may be some cut injury, or there may be it blocks the blood supply. So it is very harmful for the diabetic foot patient. Any more question? Any question? Yeah, Ishani, you want to say something?
Yeah, I just want to ask the students any other queries? Hello, am I able to the student?
No queries, ma'am. No queries. Yes, no queries, ma'am.
Okay.
Okay. Okay, thank you so much, ma'am, from the FSTN team to be with us to give us a lot of vast of knowledge. And I have attended your